So to start our conversation, today's conversation is on physician burnout, and this will be the only time that I really get into the statistical side of it, because I think that the stories and the human side of it are much more important. But the statistics stick out so much that I wanted to just highlight those before we even started our conversation. So in Medscape's National Physician Burnout and Depression Report, the most recent one, which surveyed 15,000 physicians, and they were from 29 different specialties, it was reported that 44% suffered from burnout, 50% of females physicians suffered from burnout, 39% of men, although more men committed suicide than women. The suicide rate in physicians was the highest of any profession, even higher than military veterans, which alone was shocking. Doctors die at a rate more than double the rate of the general population by suicide, and it's an average of one doctor per day that commits suicide. They say about 300 to 400 per year, and it's tough to balance the numbers because they're not sure sometimes which is a suicide and what's accidental or whatnot. But this is not a new problem. It's been going on and reported since 1858 from what I've looked at, and it seems to only be getting worse. And it's such a massive concern. Coming from a medical school, surrounded by medical students every day who are bright and alive and so excited to be working hard towards the profession that they're going to be going into. When you see statistics like that and you hear these stories, it's mind-boggling. So I wanted to invite each of you here today just to have this conversation, which seems to not happen often enough. So if you could each introduce yourselves and kind of explain what you bring to this conversation, and then we can kind of get into our personal sides of it.
Okay. Go ahead.
Want me to go first?
Yeah.
Well, my name's Linda Seaman. I'm a physician here in Yakima. I was married to a physician, an ER physician who practiced 33 years in full-time emergency medicine. My background is also emergency medicine, which I practiced a decade in Los Angeles County, and then we moved to Yakima to raise our family. I continued to practice a ER 4 shifts a month to keep my proficiency, but then went into family practice. I had a subspecialty in hospice and palliative medicine. So I come to this table because my husband did commit suicide, and he suffered tremendously, and I have I think a very personal story to share.
Thank you for having me today, and thank you, Dr. Seaman, for sharing that. So my name is Angie Maxon, and I'm a first-year medical student. I'm fresh in the game. I have been working for 5 or 6 years to get to this point, and I came to Yakima to study medicine, osteopathic medicine, and I have 3 children, and my husband is a child psychologist. So.
Nice.
Wow. Well, when we were trying to figure out who we could have for this conversation, I thought there's no better way to do this than to have somebody who's a student right now, and you're a first-year student, you're just starting this journey, and somebody who's had so much experience in the field. Because really, it seems that the problems that go along with this start in medical school, and they start from the demands that you have as a medical student, and they travel along every step, and they only seem to layer upon themselves as they go. So in your experiences as a medical student, have you started to feel those pressures start to creep in? I know that speaking to a lot of students, when we try to do anything with them, they're always so busy with their schedules, and it seems like they work 25 hours a day, and it's overwhelming to me. So I can imagine how it feels, especially with the pressure of knowing that you're working towards something you care so much about.
Right. Yeah. I have felt a lot of pressure since I've started the process. And I thought I knew I would understand what I was getting into, but once you're in it, there's a lot of pressure, especially in the transition periods, when we first started classes, just the new schedule, getting adjusted, it was really difficult. And then as the year progressed, I found myself adjusting and actually handling everything much better. And more recently, I've added some new activities, and I can feel the pressure again and the need to adjust and to work with even more responsibilities and figuring that all out.
Yeah, it's got to be constantly shifting, and there's things being thrown at you, not only with what you're learning, but then with your personal life. You said you have children, you have a family, and you have to balance that. And it's got to be really challenging to say that anything is more important than anything else. But at times, I imagine you're forced to do that.
Yeah, absolutely. I feel like I make a choice every day, and a lot of the times I feel like I'm not meeting expectations in one area and doing well in another, and then I'll shift a little and it'll feel like I'm not doing as well at home but really well at school and vice versa. So yeah, it's a constant juggle. Yeah. And it's just, you have to be really gentle with yourself, I think, and it really helps that I have an amazing support system at home, because it's just, quite frankly, would not be possible without that. There's just no way. Yeah.
That's true.
Yeah.
In medical school yourself, again, coming back to this being such a long-standing problem, was it still something that existed back then? Was it still those same pressures? I imagine that this hasn't really changed much, and it doesn't seem like there's much changing to make it better.
Oh, definitely. I think you're always, I think in the training process, and it actually starts in college, and then if you decide to go into medicine, right, you have to perform to get into college, or into medical school, and then you have to keep performing to get into residency. So you have a very long training track. My training track was 13 years total. And in that process, this is where some of the danger starts, because you learn to deny yourself. You learn to build walls of what I call delayed gratification for a lot of things. Like Angie said, if you add something in that you like, pleasure, or maybe a hobby, something else suffers, because you only have so many hours in the day. So I do believe this these walls start to build during this training time. I think one of the dangers, if you look at the recent literature on physician burnout, is that we tend to think of ourselves as superheroes. Not that we're egocentric at all, but we are above the average in terms of denying ourselves what we need. And one of the first things to go is emotional engagement. And we can talk more about that, but compassion fatigue starts truly in your clinical years, because then the responsibility escalates. I actually look back and think medical school and residency were fun, even though I was up every other night on some of my rotations. I was physically and emotionally exhausted. On the other hand, that was fun compared to transitioning into clinical practice, where you were the boss, you were the bottom line, and you were the target.
With that superhero idea, so many people, I would imagine almost everybody who gets into medicine does so out of a selfless place. They're looking to care for others, and when you constantly care for others, you're putting them above yourself.
Absolutely.
And when you're dealing with the stress, whether it's sleep deprivation or the anxiety of not succeeding in a class or losing a patient, something as horrible as that, which is an everyday occurrence for many physicians, you don't have the space, or you don't even have the mindset, I would imagine, to care for yourself, because you're trained to care for other people.
That's very, very true. And I think it's one of the danger zones that the young doctors need to be very much aware of. And we can talk about what I perceived as the transitions. For me, the first transition was physical exhaustion. Managing my stress. I was used to managing my stress. It was just part of everyday life. When you don't have time, you manage your stress well. And for me, the understanding of burnout came when I couldn't manage my stress. I didn't understand that I couldn't manage my stress. I understood that I felt depressed. I felt when I looked at an admission in my ER, I wouldn't see, my compassion would not be there. It'd be, oh, this is a lot of work now. I have like 5 admissions. I haven't slept. I'm going to be up all night. I started to see patients as being work, and yet that training process, like in the military, trains you to not lose your intellectual capacity. So the emotions start to go numb. You're physically exhausted, but you learn how to perform, and you always try to perform well at the top of your game. And I found that, looking back, to be amazing. I felt it an amazing life skill, but I didn't recognize how I had compromised my personal resiliency, if you will. And it was only when I became very depressed. I was blessed to meet with the head of psychiatry at Harbor General Hospital, which is the little county hospital that has only 700 beds in LA. And he taught me two things. He taught me, one, when you are meeting your limits, you need to make a change and take that risk. And two, set limits. And he also taught me, because we have some endogenous depression in our family, he gave me the advice. He said, when you get stressed, depression will start to kick in for you, maybe more than other people. So you need to consider not doing things that put you over the edge, like working nights, like limiting my time in my clinic. He encouraged me, and boy, that was a lifelong lesson that I took to heart, and I try to convey that to the students.
Even with advice like that, I imagine it must be so hard to take the advice, because the profession is life or death. And if you're taking time off, and if you're saying, I'm going to do this for myself, there's a real guilt, I would imagine, that comes along with anything that happens in the time where you're away.
Right.
I would assume that, again, with coming back to the idea that this is one of the few professions that people face, there's a revolving door, and people are coming in, and they're usually in the worst moments of their life, and you're seeing them every day, and that sort of becomes your life. And the inability to ever reach a conclusion with that has to be exhausting.
It is exhausting, and I think that's why the highest rate of burnout and suicide is in the emergency medicine profession right now. Some of the statistics you shared, I would like to just comment on, and one is that in the state of Washington, we're doing very poorly. We're double the rate of burnout than other states. And number two, the specialties have changed. It's always been high risk. If you're in emergency medicine, OBGYN, anything on the front lines now, family practice, internal medicine, pediatrics. The other key component are the specialties that have isolation associated with them, because you lose a sense of connection with the camaraderie of your colleagues, like radiologists and anesthesiologists. They're top. So, interestingly enough, the psychiatrists are at the bottom of the list of risk. I think they learn a lot of this self-skill in their training, actually, and maybe implement it much better. So, and the other thing I think is important statistically to know is that I believe the rate of suicide is probably twice what you quoted, and it's because physicians go to their colleagues and they try to not document mental health issues. They try to not document, because then you have to face regulatory scrutiny, or you get reported as, quote, an impaired physician. And, you're a very competent, confident, intellectual person, and you can't expose that, because then you're weak. And that's not part of a physician profile. So I suspect that the suicide rate's about two a day because of lack of reporting.
Wow. Yeah, when you look at it that way, if you're expected to be caring for other people in their times of need, and you can't even care for yourself, that's probably how people look at it. Yeah. And if I can't take care of myself, how can people trust me to take care of this person? And you'd cover it up. I would imagine you'd have to cover it up, and it's kind of a necessity, and as is the emotional disconnect from your patients. And I would imagine that becomes so damaging, even if you're not aware of it. But if you see people every day and you connect with them emotionally, and you lose them, or they have some sort of a terrible thing happen to them, then it's going to do so much damage to you, where if you kind of shut them off and start to look at them as something else other than a person, it's a self-protection measure. That
definitely. And I was going to say, and that's why patients always say, well, he didn't have a good bedside manner, but he's really good. And and that's exactly what it is. You do have to wall yourself off, or you wouldn't be able to perform.
Mm-hmm. When you were getting into medical school and coming into this, with your husband and the profession that he has,
Right.
you must have been aware of these sort of things where I don't think much of the general public is.
Absolutely.
Was that something that shaped your decision or had an impact on it at all?
It has had an impact on my decision. Wow, he deals with the worst of the worst when it comes to children and their families. And what I've seen from him is that he maintains a hopeful attitude, and he states that's the reason he is able to continue to do what he does. I don't know if I could be in his position day after day after day, but I think I will find myself in similar situations. Mm-hmm. And I hope to learn from him and to take his advice. And I think he's right. I think, maintaining a positive outlook and, the positive outlook and just trying to feel well, feel good helps him to continue to do what he does. So definitely, yeah. Yeah.
In medicine, when you're treating patients, I would imagine that the bad news that you have to deliver far outweighs the good news that you're able to deliver, and the miracles sort of cures that you can help people with are few and far between. When you're constantly dealing with that, it must feel like failure. And when you know how hard medical school is at this point, when you go through the entire experience of medical school and ensure that you know everything that you need to know, and then you go through residency and you continue your training and you come out the other end and you're still not succeeding, or you're feeling like you're not succeeding, even something as simple as that, no matter what the profession was, if you were, putting a ball in a hoop and you kept missing every time, it would be frustrating. But the idea that you're really having an impact on people's lives and the work that you're doing, there's such a weight to that. And I imagine that with this profession alone is one of the highest causes of these numbers being so high.
Well, I have two comments, and there was a woman I heard speak on diabetes management just a couple months ago, and it was amazing. She said, it was a paradigm shift for me as a family practitioner. She said, you never see all the good you do. The patients that are well managed, the patients that don't need to come back, you're only seeing the people you still need to keep treating. And she said there's thousands that are doing great. And she said, make sure you focus on that. Make sure you remember how many people you are facilitating wellness and good health care. So that was a wonderful paradigm shift for me. Number two, I use a little acronym called Stay on the Map, MAPPE. And I tell physicians, you've got to remember why you went into medicine. So meaning, you have to sustain a sense of meaningful work and know that you are making a difference. And that nurse at the other conference really made me think about that. The other thing is we're achievers. So I always say celebrate every achievement, every board exam you pass, maybe every clinical test you pass, but certainly when you get a patient well maintained, celebrate it, talk about it. And they say in resiliency discussions that bring more people into your practice that you can make an impact on, that you like. You as a physician have control over your practice to a certain extent. And so, look for who are the kinds of patients that make me feel good, that I'm really good at. And that's why a lot of people do these subspecialties. It allows them to do what they love. The P is keep pleasure in your life, whatever brings you pleasure. And there's lots and lots of, might be loud music. For me, it's going to my cabin and listening to the elk and getting muddy, whatever. But keep pleasure in your life, and then personal balance, like you were talking. You must engage with a support system, whether it's if you're single, it's got to be your, group, your guys that you go motorcycling with. But I tell the medical students, you got to schedule those things into your life. They don't just happen. They'll go to the bottom of the list.
Absolutely.
So your personal balance has to be the top of your list. And then the E is engagement. Stay engaged. Stay engaged. It doesn't matter what's going on in your life. Is the cup half empty or half full? Mm-hmm. You got to look at it's half full. The empty is going to come. People get sick. People die. People don't do well. It's not your fault. And that's the balance. You can become depersonalized and not care, or you can stay engaged and care appropriately, but realize this is just part of your job. Mm-hmm. And keeping that perspective in your engagement will build resiliency.
Mm. Now, when you were deciding to go into medicine, mm-hmm. You made the choice, obviously, to go into osteopathic medicine. Mm-hmm. And when I speak to a lot of our students and even our faculty, they say that one of the benefits of osteopathic medicine is the patient-to-physician connection, and the idea that you can spend time with somebody and really understand their life, the things that shape them just outside of the clinic, whether it's their job or their family life or their diet or whatever it may be. One thing that I kept reading and looking at these all these terrifying statistics was the idea that the amount of time that physicians get to spend with their patients seems to be shrinking more and more, and they have to see more and more patients, and you lose the ability to connect truly with people. And while, again, we could come back to the idea that maybe that's a benefit because you don't have the personal connection if something goes wrong, you don't get into medicine for that. You don't get into medicine to be cold and to be have a stranger come in the room and give them something quick and push them back out and have somebody else cycle in.
No.
So
could you talk about your decision to go into osteopathic medicine, and how did that those factors shape that?
Yeah. So I guess mind, body, and soul is one of the big focuses in an osteopathic school, and I'm really into that. I personally, if I'm not feeling well, and I engage my body or, take some time to be mindful, it affects my entire being, right? And I think it's just extremely powerful, and I want to work with people in a way that incorporates every aspect of their life. And I get that we're limited in our interactions, but to be aware that family relationships and hobbies and work and diet and exercise, they all affect your patients, and they're all very, very important in considering how you care for them and how you care for yourself. And I really appreciate that philosophy. I have a whole background in psychology, which is what I studied before, and to incorporate that knowledge and my excitement there, along with medicine and social aspects as well. I just find it really hard to think that you can compartmentalize all that and be an effective physician, which I know there's a push for that because you are, stressed for time and have to manage a busy schedule, but, it's just a part of your patients, and those need to be brought in and addressed. Yeah.
In your years working, the balance between connecting with patients and really figuring out their lives and getting close to them, which is so important for caring for them in a way that's going to be beneficial, and avoiding connection with them because of the idea that you may suffer a loss through that. How did you achieve that balance, or did you?
Well, this is where it's probably appropriate to bring up the topic of graduating. You get through medical school, you get through residency, you're well trained, and then you graduate into being in practice. I learned a lot in my hospice years. I spent 20 years doing hospice advocacy and development of the career, and they have a big circle, and the circle is your culture. And inside, this is how you die well. Well, this is also how you live well as a physician. The big circle is the culture that you're in. You have to consider your culture. The inner circle is the community you're in. And then you have the patient and you, who are the caregiver. So in hospice, it's a caregiver. In the living well, it's the physician. And that relationship is the center of how you effectively care for them. And that bond is very powerful. And there's lots of literature that'll say if your patient bonds with you, you have a lot of influence on their life. But you as a physician have to take into account their family, their community, and their culture. And so it's a very complex decision-making process that you have to manage. So when you get out into private practice in the early 90s, I loved it. I was in family practice. I loved it. I had my schedule under my control. If I knew my patient's daughter was really ill or her husband had just died, I could schedule 30, 40 minutes. Well, what's happened to physicians, and this is what has escalated the burnout and the suicide rate, in my opinion, we now have hospital systems that are telling you how to practice medicine, and you've lost control. Physicians by nature need to be in control to be good physicians and to practice well. So I personally didn't really have a lot of fear of losing, having patients, have bad outcomes, mostly because my training was in ER and I saw that so much. So I experienced a lot of bad outcomes every day. So that didn't impact me at all. I just wanted to practice better. And I have been very unhappy in the last 15 years with being told I can only have 10 minutes. Because of productivity. I feel like I'm being treated as a rat on a treadmill, and I'm a very overpaid rat, if you will. Number two, EMRs hit. Hospitals received over $18,000, $20,000 per physician or provider from the government when EMRs were implemented into the healthcare delivery system. One of my jobs, my last job that I quit, was because I was spending 75% of my time being a secretary, checking boxes, sitting at a computer. I'm 64 years old. Maybe the younger generation won't be so hard. But I could see my patient make a decision and get them on their way, and then I'd spend more than that time sitting at a computer documenting what I call meaningless, not useful information. Medicare calls it meaningful, useful information. It's ridiculous. So you have the EMRs, then you have litigation. Litigation escalates. You do everything you can for a patient. You refer them. You do the best you can. We're not gods. We are perfect. We are human beings. And I think society forgets we are human beings and we do care. And you get a bad outcome or you don't get a bad outcome. And then you get hit with a lawsuit for somebody you took care of in the middle of the night with 20 other people. That physicians are not wired to take that. We take it personally. I don't care what anybody says. It's not just business. And economic gain has been the modus operandi for the last 15 years in this country. And I think physicians have been used and abused, and they can't take it. So they're retiring early, they are dying, and they are quitting. I have colleagues who quit. They were 40 years old. After all that training, they've quit. They will not and cannot sustain a meaningful life in the kind of system that's created. And I feel very, very passionate about trying to push back against that system for the young doctors. It is not why we go into medicine, and we are not rats on a treadmill.
For each of you, and this may feel like something that you've been asked in sort of a more canned approach, but why did you go into medicine? Because I feel like that's a very important approach to go into this conversation, and I imagine that it's something you constantly have to remind yourself of throughout your career.
You do. I went to college at Vanderbilt University in Nashville, And I didn't have any money. I was very poor. So I went through in 3 years. And I was an interdisciplinary Chinese major, which is kind of strange, but I loved the Chinese culture and so learned the language. But in addition, I took pre-med courses because I always wanted to do medicine. And I ended up working in the hills of Appalachia 2 summers as a college student with Vanderbilt medical students and nurses. They went out into these rural areas of Tennessee, and I was shocked that there were people who lived in these outback areas who'd never seen a doctor, ever. And so the diagnoses that we made were amazing. And I mean, I was just kind of a helper type because I was just in college, but I just thought, wow, I want to do this. I can make a difference in people's lives. And it was so engaging to be a part of their lives and then to get them the help they needed, or maybe they wanted, but a lot of them wouldn't drive to Nashville to get the help. And it was like, well, let's figure out how you can at least take care of, getting this surgery done. We'd make diagnoses of advanced cancers, or they just lived with it because they didn't want to get out of their little hollers.
Yeah.
So, but I loved working on, it was called the Student Health Coalition. And I loved working with the medical students and the nurses. And I thought, I want to do this.
That's really cool. Well, I didn't know what I wanted to do for a very long time. And like I said, I went to school and I graduated rapidly. I only took 3.5 years to get through college the first time. And I thought psychology was what I wanted to do. And then just sort of following my husband and his career, I realized it was just part of what I wanted to do. I really needed something that would incorporate that. And I discovered that medicine was really more for me, where you can, it's not that you can't, give a solution to somebody with therapy, but to have solutions that do include osteopathic care or medicine, even prescriptions. There are it feels like there's something more tangible at times, and I have an appreciation for that. But really, medicine, it incorporates all of my interests, like I said before, with more of a biopsychosocial approach. And as I worked towards another degree, about 10 years later, as I didn't have the prerequisites needed to apply to medical school, I started to work as a nurse's aide on the psychiatric unit at our local hospital, and I cared for both the geriatric patients and the adult patients, and it was probably the most meaningful work that I've ever done. It was quite amazing, and it was personal care, and it was the job that nobody wanted to do, and it was hard, but I felt like I had more skill and the whereabout to work with patients that had severe dementia and behavioral issues, which is typically why they would end up, at the behavioral health unit. And it just was really gratifying to help people in their time of greatest need, and also at the end of their life, when they needed more care and assistance. Even in some of them passed there, and it was so gratifying to be there with them and to help them through, whatever it was that they needed in the moment. And so I just kept forward. Everything I did as I worked towards medical school just kept perpetuating me, and it just felt right. It was where I wanted to be. Yeah.
And taking an approach like that, there's such passion in your answer alone that you can see that sort of passion you would imagine would carry over throughout everything that you do, but with the constant force back of whatever you care about and whatever you've gotten into this for, it doesn't matter at this point. And this is the reality of it. It has to be another completely exhausting piece of everyday life that just wears you down. You've mentioned that you've dealt with this personally, as did your husband. Can you talk about some of the experiences that you had that kind of put you at the edge of being part of these statistics of burnout and facing the idea that you've gotten into the wrong profession, or that the work that you're doing isn't valuable? Or
Well, the first time I did 2 years of general surgery at Harbor General, because I loved being in the OR. I loved fixing things. But I was up every other night on some rotations and every third night. And at the end of 2 years, I was just physically exhausted. And at that time, there was quite a bit of gender bias. There were only 10 women in my medical school class. To go into general surgery, I think there was only one other woman even interested in that. And honestly, I didn't like my mentors very much. They were very condescending, chauvinistic, and so as a woman, I had to be better than them, and I was, but not in a technical way, but I mean in a what I could perceive to be an emotional way. But it wore me down, and so I said, I'm not going to do this. So I quit after 2 years of general surgery, and I'll never forget it. Of course, I'm in Los Angeles. I literally sat on the beach, Venice Beach, if you know Venice Beach. It's the most amazing, crazy place. And I remember I just slept. I'd sit down the beach and watch people and slept, and I just thought, I don't know what I'm going to do. But then I had the skills to work emergency medicine, so I started what they call moonlighting and just earning some money. You only have to work 1 year to get your license to practice, the internship the first year, and then you take your exams and you have a license. So I started working emergency medicine, and I did that for 4 years, and I loved it because I could work really hard, but then I could travel, and so I started traveling. In 1985, a very dear friend of mine called me from Harbor General and said, Linda, you really should finish your residency. It's not good to not finish some kind of a formal training. And I'm like, yeah, right. Well, I really like what I'm doing. And I'd bought a house. So I was like, and she goes, well, you think about it, but we have a spot at the second year level. So you wouldn't have to repeat your internship. I was like, well, that's good, because I wouldn't. And so Harbor took me back in as a second year resident, and I finished family practice. So
wow.
But because of my ER experience, I became double boarded in ER and family practice. So it gave me the best of all worlds. Then the second burnout is the one I mentioned to you during that residency day, where I just, you do good with your stress. And stress is when you can still manage the load. But I was engaged, and we broke off the engagement. You throw in some personal issues. I was alone. My parents had moved to Saudi Arabia, so I really didn't have family around. And I became very, very depressed and suicidal. And it only took about 3 sessions. I think we're fast learners, right, Angie? And you think, okay, I can get this together. And, the psychiatrist really put me back on track. And I started prioritizing what I did and when I did it. I actually started pushing back even with my mentors. They'd want me to come in and help as first assistant for these long cases, just because I was their, what in medicine we call it your scut monkey. You have to do what they tell you to do. And I had so much work to do, so many other things to do, and I started pushing back. So it created confrontation, but I said, no, I'm not spending 8 hours in the OR. I don't have that kind of resiliency. I'm tired. I'll help you for 2 hours, then I'm scrubbing out. And, of course, they didn't think that was very good, because I was pushing back. But I had to do a lot of pushback in my training years. And I think being a woman was part of it. I had to push back against a lot of the gender biases. But residency tends to put you, it's a very hierarchical system. And if you're on the bottom of the hierarchy, you just, it's like the military, you just do what they say. Yes, sir. So I started to push back, but the only reason I could push back was because I'd been out in the real world for 4 years. And I knew what happened in the real world. And I thought, residency's not the real world. And you know what? I'm a person too. And, you know, I think I gained respect from most people once they got it. But it was stressful for me. But I did that. And it just made me stronger. So that was my second burnout. And then my third burnout. So just get ready, Angie.
Okay. I mean, to hear your responses.
My third burnout was after getting married. My husband and I went through a very difficult time of trying to have children. So, I mean, that's why we got married. We were both done with our training, and I lost a baby boy at full term.
I'm sorry to hear that.
So I got depressed. Again, life happens. You have to be a doctor. You have to do all these things. But life happens, and it's not easy stuff.
No.
So if you don't have a core resiliency, life, when it happens, pushes you over the edge. So I took a year off after that. I just couldn't see patients anymore. I didn't want to see anybody really. So, but the burnout came because I think I was. In fact, I'll tell you the story. I was in the emergency room so I lost that child. I learned a lot. My faith sustained me. I'll be perfectly honest. My faith and my support system. If I couldn't see the reason for what I was going to do in my future, I would have quit medicine right then and there. So then my husband and we lost several miscarriages. Then I had my little girl, who's now 25. And, you know, she was a miracle, but I was working in the ER. I was 7 months pregnant with her, and I started having preterm labor. And I'll never forget this. I sat down, and I said, you know, I told the nurses, I said, if it's not an emergency, I'm not seeing it. And it was a small ER. So I sat down, and I put my legs up. I said, it was like 4 a.m. I had 3 more hours till the shift was over. And we didn't have any emergencies come in. We had a few patients, you know, with baby crying and runny nose and things. But so they were sweet, and I laid down, and they held the patients till the shift and told the doctor why. And I went home, and I didn't work again until after she was born.
Wow.
So, I mean, that's not really a burnout, but it's an example of what you have to do to prioritize and take care of yourself. And you know what? You get pushback. You know, people, oh, well, you can't work here anymore because you're doing this, you're doing that. And I'm like, fine. That's why you have your more than one egg, your eggs in more than one basket. And, you know, you just have to be willing to take those risks and do what's right. And she's an amazing daughter. So best job you'll ever have, right? You know that.
Absolutely. It totally
Never
is.
compromise your children.
It's one
ever.
of the hardest and one of the most gratifying, you know, I've found.
Yeah.
It just seems like when physicians or med students, whatever level of training you're at, if you're functioning out of fear of losing a position, fear of whatever it may be, it seems like that's where we're going wrong, I guess.
Yeah.
You know, like you said, it's about risk taking.
It is. And knowing, I tell the medical students this all the time, they need you. You don't need them.
I like it.
They need you. You're the expert. You're the one with all the training. So if they're telling you to be a rat on a treadmill or be a secretary and fill in EMRs for, you know, half of your time, and you're like, this is so stupid, I could, you know. And they even told me, I said, well, why don't you hire a scribe for me so I can do more, you know, more. They were on my case about productivity. And I'm like, you know what? Hire a scribe for me. And these hospital administrators goes, oh, well, you can hire them out of your salary.
Whoa.
I mean, it's so insulting what is going on in medicine.
I was a scribe for 2 years in the emergency department where I came from in Montana. And I spent, the shifts were 9-hour shifts at that emergency department, but I would spend 9 to 12 documenting on the behalf of the provider, and most of it was clicking buttons and filling in circles and double documenting. And it's amazing to me the workload, the paperwork that is associated with one patient visit, the physician can care for that patient very quickly and effectively and appropriately, but the documentation that comes along with it is
it's double or
it's
triple.
at least, yeah.
And
yeah.
and it's coming from insurance companies. The health insurance industry is very greedy, and so are hospital administrations now. And what kind of makes me mad, if it's okay to say this, but they've done this to us. They've made the escalation of burnout. They've burdened us with non-clinical things, and now they have all these wellness programs that are springing up. But I want to tell you why those wellness programs are springing up. They are not springing up out of care for the physicians. They're springing up because the dollar sign's being impacted. For every physician that retires, quits, or commits suicide, to recruit, replace the physician, rebuild a panel that they lost, it's easily $500,000. And only because that economic data is coming out do they care. So I have a great angst about what's been done to physicians, and it's just not right.
Yeah, coming back to that idea of them needing you, when I was, again, looking at these statistics, with the amount of suicides that happen per year, they estimate that over 1 million people lose their doctors in the United States due to physician suicide. And with the shortages that especially rural and underserved areas already face, losing your doctor, especially somebody who you've developed a relationship with, who you begin to trust with your own health, that's devastating to the patient as well.
Yeah,
so
it
this is a problem that not only impacts the healthcare community, but it impacts every community that the healthcare community impacts, which is everybody.
Which is everybody. Yeah. And we've already developed a more fragmented system, mostly because of insurance mandates. People can't go see this doctor because now they got this insurance coverage. And we fragmented our system by introducing hospitalists. It used to be your patient goes in the hospital, you see them, and you get consultants to help you take care of them if it's out of your skill set, but you still retained a relationship. When I went in the hospital with my mother-in-law when she got very ill, if I hadn't been there, she'd probably gotten 3 CT scans of the same thing. Patients are... And that's driving up healthcare costs. But you know what? They don't care. They just make money. So, that's this whole thing about how money, they say, well, why have healthcare costs gone up? Well, defensive medicine. I don't care if you don't want a CT scan, buddy. You're going to get it because I don't want to go to court.
Right.
Okay. Number 2, I don't even know, you don't even know what my mother-in-law was in here for last time, and now you're taking care of her again with, recurrent AFib and seizures, and it's like, what do you know? You get sort of angry if you're a physician because you know the difference, but, your general public doesn't know. And, hospitals mandate that physicians order enough tests or they start kind of harassing you. That's unethical, in my opinion. I mean, and then now you have patient or physician profiles on the insurance websites. Well, you don't make the good doctor 5 stars unless you've been in their camp ordering lots of money and making money for them. People don't realize that greed is what's running the healthcare industry, and physicians have been assaulted and insulted, and that's why it's getting worse.
One thing that I always hear from students, and I hear from our faculty again, I think when people picture doctors, they picture somebody who's in this really affluent profession, and they're making a lot of money, and they're very well off and comfortable in their lives. But working at the medical school and speaking to our students, you can see the stress that comes along with taking on the student debt that medical school brings.
Oh my gosh, yes.
I imagine, again, that's another huge factor in when you're signing up for this. You're doing so, and everybody that I've spoken to, they know that they're taking on that debt, but they're doing it because there's a cause that they're looking to fill. They want to take care of people. And when you take on that debt, you do all this work, you get into the profession, and you find out that your strings are being pulled to the point where you can't take care of people the way that you've always imagined. That again has to be devastating and another massive factor in these terrible numbers.
Well, and that's why I say don't get trapped. Remember, I
Yeah.
said that I have a friend in town who's a family practitioner. She's a little older than me, and she'll say, "I really feel bad for the young doctors." She goes, "They're going to be the highest paid indentured slaves I've ever known in this country." And I couldn't afford to go to medical school if I paid $5,000. I hate to say at my state
yeah.
school, and I don't even know what your tuition is here, but. That's obscene, and it's in all our higher education.
It's
you
true.
know.
Yeah, it's not specialty medicine.
Kids don't
but-
go to college because it's too unaffordable. It's really, we have some pretty backwards values in this country, in my opinion.
Yeah, education, it's a privilege. It's not something that, at least in the United States, is a right or given to, the opportunity is not offered to everybody. It's true. College is very expensive, and graduate or beyond is even more.
Exorbitant.
Yeah, and I had many people, try to persuade me or dissuade me really from going to medical school solely because of the loan debt that I would be accruing. And, for me, I'll deal with it as it comes. I can't focus on the loans. I wouldn't get through. It just isn't realistic. But I am taking steps, scholarships, and, there are ways to manage it as you go. And then, service is ultimately how, for example, my husband is dealing with his incredible loan debt, public service. And I hope to do something similar. But again, then you are sort of under someone else's control, sort of. You owe so much time, or, I would imagine then you're kind of under their thumb with how they run their organization or business. And
Well, and they know that. That's so I actually have taught contract negotiations at the school. Periodically I'll go out. I did it for 3 years, and then last year I couldn't do it. But one of the things I tell the students is, other than they need you, right? You don't need them, but also don't listen to them when they say, "Well, this is boilerplate. This is what everybody does." You know what? You can negotiate every line of a contract, and loan forgiveness is often part of that. And they'll tell you no. That's why you have to be a risk taker.
Right.
You
I
have
can
to
see
be able
that.
to walk away from. They want to control you, and they'll ride your hide if you're not producing for them. And you know what? That is so insulting. I mean, I don't know why patients don't rebel, because they don't like to be pushed in and out. They don't like their doctor sitting at the computer the whole time while they're trying to talk. I mean, you ask any patient, they don't like that. Here we're all doing what we don't like because somebody's trying to make money off of us. That's just wrong.
One of the great shames of this too is I would hate for this conversation to dissuade anybody from going into medical service, because it's so needed. We need doctors, especially are you from Montana?
I am. Oh, yes.
Places like
Underserved.
Montana,
Here, Washington.
there are massive gaps in healthcare, and people need doctors. And
Absolutely.
the idea that we're pushing people away from the profession that's so needed and so beneficial to so many lives is it's sinful, really.
Yeah, it's not good. And I also think that the what Angie just said is the heart of medicine. The house of medicine needs to have compassion brought back into it, because that's why we do. Why would you get a $500,000 debt? Why would anybody do that? That's why more women are in medicine. When I went, there were no women in medicine when I went to school. Now it's mostly, it's about 50% or more, I think. But women like that. Men, they want to make, they're the breadwinners, the providers often of the families. And they're like, well, I don't think I want to do all that and do the debt. I mean, they're not going into the field. And the other thing is, I've been told to my face by hospital administrators that and I make less money than I made in 1990 when I started, less, as a family practitioner.
Wow.
I've been told to my face, well, it's okay. If you don't want this contract, we'll just hire a PA. And I have nothing against physician assistants, but they have 2 years of training.
Mm-hmm.
I have 13.
Yeah.
I am not feeling valued as a human being. And you have to be strong enough to, again, say, fine, I'm not working for that wage.
Yeah.
So do your homework.
It's interesting, too, that you said that more women are going into healthcare, and maybe, I don't know, I was reading something about how, well, actually, Paul, you said, too, at the beginning that, about 10% more of physicians that are burnt out are female, and I don't know if that's just because the number of female providers have gone up, but I can only imagine sort of why with the social roles and then the professional roles that we have to play. It's just an interesting thing.
Well, women take on a lot of, and I survived by obviously being very good at multitasking.
Right,
but,
absolutely.
But my job was to take care of my husband and my children, and my career had to take second fiddle. The beauty of, in retrospect, is I learned how to be an entrepreneur, which is what I didn't think I could ever do. But I started doing contract work. I would, find odd jobs. I felt like I became the queen of part-time jobs, but actually I kind of liked it. But you have to be able to take risk and enjoy change.
Yeah.
And a lot of people can't do that very well. And so I think women naturally take on a lot more multitasking and multiple hats. But women also get more depressed and get burned out, I think, than men.
Yeah.
We're not as good at living in the little compartmentalized boxes that men can. I learned how to do that now, though. I'm pretty good at it. But I had to learn how to do that.
Yeah.
When I was looking at this, it's an undercovered and underspoken of thing, but there are plenty of people writing about it and talking about it. But I think what happens is the statistics, no matter how shocking they are, seeing 44% feel burnt out and 50% of females and all those things, what happens when you look at only stats is they become numbers and they don't feel like there's a real a human element to it. Dr. Seaman, you have, unfortunately, maybe the greatest direct human element of this story to share. Can you bring that to this conversation? Because it's so important to understand that this is not just a statistic that stands out on a page that makes your eyes open, but it's an impact on a life, and it's an impact on not only your life, but so many lives.
Well, like I said, my job was to support my family first. And my husband, as an ER doctor, I think when my little girl was growing up, we only had 4 days a month that we could have dinner together because they were 7 to 7 and he'd have to leave early and come home. So we never had a norm in our life, right? Biorhythm shifts were constant. I think one of the beauties of my husband was I saw him circle the wagons to survive, because even as he aged, and this made me mad, a lot of things make you mad as a wife, right? I mean, here's my husband in his late 50s, and he's being told he has to do the same share of night shifts. That's a system problem. You can't do recovery from a night shift when you're 55, 60, like you can when you're 30. And they know that. But it's the dollar sign. It's all this craziness. The other thing is, so my husband understood how to be resilient. He had amazing hobbies. He had amazing passions. And he spent his time in those arenas to recharge. And people need to do that in medicine regularly. But unfortunately, what happened to him, and it's a fairly harsh reality, which I hate to even share in front of Angie, but, he was doing well with retirement. One of the highest rates of suicide in physicians is the first year into residency and the first year of retirement. So he had retired. He came home one night and said, I can't handle this insanity anymore, and that was it. I said, okay, time to retire. So he had retired, and 6 months into retirement, he got hit with some litigation. from 2015. And I can't really discuss that, but there were no damages. But then this complaint went to our regulatory board, MQAC, Medical Quality Assurance Commission, which is supposed to monitor, quote, public safety. And they don't get that many complaints, but when they do, they just go after them. So here's my husband, 33 years, full-time ER, saved multiple lives, gets an MQAC investigation. It goes from bad to worse. And because he's retired and because he doesn't want to spend personally $50,000 to defend the allegations, he just signed it and said it doesn't matter. So it's basically like a dishonorable discharge from the military. So then that creates a cascade of events where they take your license, and when they take your license, you go to the National Data Bank, and then when you do all that, you lose all your board certifications. And he was still board certified in emergency medicine. So very proud, very competent, very intelligent. So he has to go through, quote, what I call an inquisition, gets this dishonorable discharge, and he compartmentalizes it and says, well, I'm retired. Who cares? I don't need my license. I don't need this. But one complaint led to that. That's not uncommon. And physicians need to fight back against these regulatory boards. So we tried to just sort of go, well, whatever, who cares? Well, guess what? Next thing you know, this MQAC allegation, which he did never agree with, it's an allegation, if you know legal terms, was fuel for fodder. And this particular plaintiff then filed a lawsuit and went after him with a very vicious Seattle attorney. And you know what? He took his own life 2 days after the deposition. And my husband wasn't my husband for about 3 months. He'd been stripped of his career, everything he'd done and given to humanity. And we allow a regulatory board to do that to physicians? He's a hero. He received the Hero Award here in Yakima Valley from the American Red Cross. He received a Hero Award from the American Board of Emergency Medicine. Out of 36,000 board-certified emergency physicians, only 1,100 ever reached the 30-year mark.
Wow.
He's a hero. And we allow MQAC to do this to our physicians. And then it became fuel for fodder for a vicious lawyer who's going to defend somebody who has no damages. He couldn't take it.
I could understand that. Spending so much time caring for others.
Depression went from bad to worse. And robbed me of my retirement with my husband, my best friend for 40 years.
I'm so sorry.
It's so not right. Anyway, I feel like I do want to talk about it because I think it's so wrong. Public doesn't know. It's just so wrong. Anyway.
Thank you for sharing that.
Yeah.
That's an incredible
story. Well,
story.
thank you for asking. And I wouldn't be here if I didn't feel it was important to talk about.
Mm-hmm. With it sounds like he had such an amazing career.
He did. He saved 5 or 6 doctors in this town in the first 5 years he was here. I mean, and look what that did. He saved, a neurosurgeon, a cardiologist, an ENT doctor, in the front lines. And they had full practices, right? And look at all those patients that they continued to give to. I mean, he was the best. He was a Phi Beta Kappa Stanford graduate. I mean, he was the best of the best. So, anyway, thank you for asking.
Thank you for sharing. I'm so sorry for your loss.
Okay.
Now, somebody like him who's spent so much time in the field and done so much great work, the idea that even he could fall victim to these sort of things it's as eye-opening as anything. And it really reveals how important this conversation is. So I'm so thankful that both of you join me today.
Mm.
What I don't want to do is, again, end the conversation on the note that this is a futile enterprise, that you're going into a field that...
No.
It's not.
So what I want to talk about are some of the approaches that each of you in your experiences, whether it's as in all your years in practice, or you as a medical student, or your experiences with your husband, things that may be able to shift, or advice that you have for people in the field. And you've already given so much great advice to make sure that this problem, which again seems to keep escalating and getting worse and certainly isn't improving, doesn't continue, and that we can make sure that people like you, doctors who are needed, can get the training that they need to go out and change lives and save people, and not be discouraged by these numbers, and not be discouraged by all of the things that shape the career that shouldn't really, when it's a career that's driven by people who want to help people.
Who care so much. Thank you. Well, I think the take-homes are kind of what I said, stay on the map, the MAPPE, continue to know why you do what you do, the meaning behind what you're doing, celebrate all your achievements, retain personal pleasure, focus on personal balance, and don't compromise your family, your own health, and then stay engaged. I mean, I became engaged with palliative care because it spoke to me as a subspecialty, and and then now I feel engaged to really help young doctors be resilient. And if it requires pushing back at these, greedy entities that destroy people's lives, then I will do it.
Yeah, that advice is very powerful, and I believe a lot of us, work towards putting that into practice. I still think there is obviously a breaking point for people, and conversations like this are so meaningful and really important. And I think changing the culture of medicine is really important in overcoming this.
And layers of resiliency, include first your family or your significant others, certainly your collegiality. Our community kind of fell apart when the hospitals demanded, and we submitted. We're so busy. We don't want to fight things, right? Doctors are so busy, and they just joined the medical staff. So a lot of our collegiality went away. We became more isolated in our little worlds. Then we became fragmented because we weren't doing continuity of care. And then we allow litigation to go on. And there's just too, and then these regulatory boards, they're so inappropriate. Yes, there's some appropriateness, but that, you know what I mean.
Yeah.
But those layers of resiliency, you just have to maintain consciously. I mean, it has, to me, it's mandatory, but it has to be a conscious and intentional part of your life and your planning. And take time off if you need to. Be that risk taker we were talking about at the beginning. They need you. You don't need them.
Well, and how can you be there for them if you're not you?
Exactly.
Yeah.
That's exactly right. As one of the authors of a recent burnout article wrote, we have to put compassion back into the house of medicine. Compassion means coming alongside passion, and our passion is to help other people. And we know more than anybody else about how to do that when it comes to their health. And it's not just physical health. No. It's emotional health, it's spiritual health, it's social health. We address loneliness, it's financial health. We are that relationship, and we have the ability to address all those things with our patients. And we have allowed insurance companies and healthcare delivery systems to pull us apart. And we've got to get back with our patients and say, this is what we need to do. And then I think we'll feel better, and the patients will be healthier.
Healthcare reform.
Yeah, there you go.
Open Pandora's box. I mean, I really would like to know what you suggest, what your thoughts are as a physician, because, I've asked other physicians and each one sort of has their own idea.
Well, healthcare reform is a buzzword that I don't talk about, but what I just said was what I meant. It's a relationship issue. We have a relationship with our patients. We don't have a relationship with insurance companies or Medicare or congressmen necessarily. I mean, we care, and we've been putting these things on the plate a long, long time. But again, I think we get taken advantage of because we're so busy. We're there doing the work that needs to be done, and everybody else kind of decides all these decisions. And, I went through the University of Washington Physician Leadership Program. It's like I forget, but I think it's 6-month or 9-month certification. And the bottom line was how to be involved with these decisions. But that's a whole nother time sink. That's a whole nother thing. We don't need, and a lot of physicians have gotten on board now. There's this is facetious, but there's medical directors of coffee, breaks, at some of these hospitals who don't do a darn thing. They're not doing clinical medicine, but they've gotten on board with the leadership. Well, the leadership isn't doing the heart of medicine, which is patient care.
Well, one of the things that kept coming out in this was the idea that people feel underappreciated in their work. And so before we close, I just want to thank you for everything that you've done, and thank you for starting this journey, no matter how challenging it is. Yeah. Thanks so much.
Yeah, thank you, Dr. Seaman. I appreciate your time today.
Yeah, I've enjoyed it. Thank you very much.